Okay, ladies and gentlemen, I think we'll make a start on this sunny morning. Firstly, a very, very warm welcome. I'm Richard Sullivan from King's College London, and it's a great pleasure to be your chair for what I think is going to be a really interesting hour. We've got 4 amazing speakers. Sadly, to talk about a perennial topic which has come up every session, I think, over the last 2 days, which is cancer control in the time of crisis. And may I first extend a very warm thanks to my great friend and colleague, Professor Teza Kutluk. We've been working together, I think, nearly 20 years now. This session is sponsored, obviously, on behalf of the Turkish Association for Cancer Research and Control. And Teza and I worked on a very long-range program, Research for Health in Conflict, over 5 or 6 years. And Teza's really done some absolutely extraordinary original research on cancer control in refugee populations. So I just want to acknowledge the Turkish Association and all Teza's leadership in this. So the strengths of this session are his. Anything that goes horribly wrong or any weaknesses is entirely my fault. That's how we're going to run it. I'm going to introduce each of the speakers as we go along. And what we'll do, I think, probably do is question and answers at the end, because I suspect there will be some generic questions and answers. And so we'll have a panel discussion, hopefully right at the end. So we'll run all four speakers. I'm not going to say much in terms of way of foregrounding this, except to say that, words like perma-crisis, anarchic, multipolar world are being thrown around. And I just want to remind everybody that Antonio Guterres of the UN General Assembly opened his remarks by saying we live in an unhinged world, which is one of the most extraordinary opening lines from any Secretary General I've ever heard. And I think we'll understand we are facing some extraordinary times. I'm sure you've seen what's going on in Lebanon at the moment. We have Gaza, we have Ukraine, we're going to hear from Nazik Hamed about Sudan. Half countries in sub-Saharan Africa are now in some forms of conflict. We're just through a pandemic, and by any stretch of the imagination, we know there's going to be another major spillover event probably in the next 2 to 3 decades of the level of COVID-19. And then finally, climate change and other factors creating some extraordinarily anomalous weather around the world, and of course issues like natural disasters like earthquakes. So with that, and I think it's absolutely right and fitting, it's an absolute pleasure to welcome to the stage Yves Anajak from Enge University and also from the IAEA. He's going to talk us through the National Oncology Services of Turkey during both the earthquakes, they had the terrible earthquakes, and also in dealing with the refugee crisis. So, Yves, please, the floor is yours. Thank you very
much. Thank you, Richard, and thank you for inviting us, Tezer, for this excellent session. So I will talk about the earthquakes and migrants. Turkey has a lot of headaches, but these are on top of everything at the moment. So the number one, Turkey hosts the largest number of refugees globally. These are the top 10 countries in the world hosting refugees, and we are at the moment have more than 3 million refugees. Most of them are Syrians, and some of them are all over the region, this including Afghanistan, Pakistan, and Iraq, and other Middle Eastern countries, and Ukraine also. So the problem started we had refugees always, but when the crisis increased in 2013 with the Syrian civil war, it was restricted to southern border provinces in the beginning, but then it spread to all over the country, and we have now some provinces, more than 20% of the population is refugees, a very, very huge number regarding for low and middle income countries. So I have to say that all migrants and refugees are not safe. Some of them, somebody is living in a tent without any food, any security, is not safe. Some entrepreneur, for example, we have Syrians who already have businesses in Turkey and who are living in a very comfortable situation, or some who find a job and taking care of elderly patients or some home services. They are not safe, so not all refugees and migrants are safe. Unfortunately, most of the refugees we have are not in this good category. Most of them are living in poor conditions. They left their homes and they don't have any skills to find a good job or position. Financing is the number one. So because of this crisis, this is the numbers that we receive. Not only Turkey, but all the regional countries. We only receive less than 20% of the money required to provide a good life for these refugees. And only some of them are for healthcare, you see. Most of them are for education, security, food, and health takes a small part. And among them, cancer is even a very, very tiny part. According to our law, to all registered refugees under temporary protection, they have the rights to access free healthcare services in Turkey, in public institutions, of course. We already established a lot of migrant health services in many provinces. Primary healthcare is free, secondary healthcare is free, and even the tertiary healthcare is free in the university hospitals and research hospitals, and only by referral, of course. So they have almost the same rights with the Turkish citizens. They also access the free medication with certain limitations, of course. So the government also invested in additional health facilities. The population increased in some provinces up to 20, 30, 20, 25%. So new health care centers were required. Usually we all in our daily life, we see a lot of cancer patients. I am from a university center, and we typically has three groups of patients. The first is new cases. So patient is coming to a new country, previously has nothing, no symptoms, then suddenly develops cancer. So this is not different than new cancer in a Turkish citizen. It is same. But sometimes their access to healthcare is developed, and most of them are diagnosed in late stages for certain reasons. The second group is who already received, get a diagnosis of cancer treatment in his own country, perhaps some sort of treatment, then migrates or escapes from the country and come to Turkey or another country, then appears in front of you and, oh, doctor, I have diagnosed with lung cancer and I received some sort of treatment. So, do you have any medications with you? Do you have any history? No, nothing. Any CT, any reports? Nothing. Any pathology report? Nothing. And you have a patient in front of you which has nothing, no record. Can you bring your records? It's not possible. So this is the worst scenario, and we are facing this every day. And the third one is those who relapsed in the host country. Coming from everything was fine, treated 10 years ago, and develops a relapse when he was living in Turkey. So main challenges, the first is access to diagnosis and treatment, as usual. The second is, as I told, the access to previous ongoing diagnosis and treatment records, which is always impossible to retrieve. The continuation of treatment, because these patients are also moving. So they migrate to Turkey, and you see the patient, in 3 months he disappears, because he's moving to another state, to relatives. Then sometimes they move to Europe, to another country, to Greece, then ending in Sweden. So they are moving. Patient movement is very high, so this disrupts the continuation of the treatment, and each time the patient's records and follow-ups are missing. The supportive care, that's another. Many of them living in basic lifestyle, sometimes alone. Family died or cannot escape, or nobody to support them, family support at home is extremely important in cancer care. Most of them do not have this. A study from my colleagues showed that 68% of the patients are diagnosed at advanced stage refugees. This is extremely high, stage 3 and 4. And 20% cannot continue their treatments. They start, but at some time their treatment is disrupted among radiotherapy patients. So, lessons learned. The main lesson we learned is from the studies of Richard and Teza. And cancer is neglected among refugees, unfortunately. So the other problems, so healthcare problems are coming first, and cancer is coming always behind. Not only those migrants, those who left behind suffer as well. Because, okay, somebody escaped Turkey and find some health service, but those who remain behind, are almost half of them cannot continue their treatment, cannot continue their radiotherapy and chemotherapy as well when there is a crisis. So that's the refugees. So what can be worse than the refugee crisis? Okay, on top of that, and last year in February, in the same region, in the southeastern Turkey, we had 2 very severe earthquakes the same day. This was extremely rare situation, having two different fault zones and having triggered each other. So it resulted in 60,000 deaths, 50,000 in Turkey and 10,000, almost 10,000 in Syria, more than 120,000 injured, millions of homes and destroyed, damaged, and whatever. It caused a lot of lives and a lot of impact in the economy, exactly the same region. So almost all healthcare services are disrupted or damaged, but oncology services, I will focus on oncology services. So we looked for the radiotherapy facilities. What happened? The region had 15 radiotherapy, in Turkish side, 15 radiotherapy facilities. And this is the highest ever damage to radiotherapy facilities in one event in the world, so far we know. Because there are a lot of earthquakes are happening everywhere, but not in such a high region with such a good infrastructure of radiotherapy facilities. So when we checked that, luckily there was no major damage to bunkers, because the bunkers are very concrete. Some minor damages happened, and some of the services disrupted. Unfortunately, we lost several staff, radiation oncologists, medical physicists, they died, unfortunately. And we don't know how many patients are dying. So after earthquake, all oncology departments ceased operations immediately. How long? We don't know. Some started very quickly, some extended some months. So with patients, we transfer to other provinces. You cannot transfer to neighboring provinces, because neighboring provinces also, 10 provinces in the region are disrupted. So all around the country, patients were transferred. Professional societies, Turkish Radiation Oncology Society, Oncologists, Medical Oncology, Pediatric Oncology Society, offered support. And they come to check and calibrate the integrity of bunkers, electronic systems, the equipment before starting delivery for radiotherapy. This happened for medical oncology as well. Unfortunately, a third earthquake after 2 weeks happened, and 2 major university hospitals damaged and stopped operations as well. So this is the worst scenario. Then the lessons for us, what will happen? The first, radiotherapy bunkers, they are strong enough to withstand strongest earthquakes, nothing happened. But the doors stuck, and so we are preparing a report now to offer some changes to design of radiotherapy bunkers and radiotherapy centers. So it should be, for example, it should be in separate buildings, not under the main building. Because it's expensive to construct a bunker, so building collapse, bunker is okay, but cannot be used because of this. So this is an interesting report. And what saved our patients are centralized online health records. In Turkey, everybody who is treated in a public center has a centralized online record. So when the patient is sent to another place, you can see even all reports and even the ultrasound pictures and all CT, MRI, everything you can access. That was extremely useful, because in many hospitals, everything is wiped out, but when the patient transferred to our center, we can access that. So national, international assistance is very important. This includes the medical industry, because for radiotherapy only, there were 24 linear accelerators stopped working the same day. So companies, Varian, Elektra, they have local teams, but having so many machines requires international efforts to come there, and not only one or two teams can repair and check integrity of this. So this includes the medical industry as well. So good national network and collaboration is required, of course. International support was good, but is it enough? No. UN, IAEA, and send support, and ASCO, ASTRO, they say they stand with us, but of course it's not enough. In Syria, other side of the, because Syria is affected as well, the crisis worsened, and even some strange things. Some of the Syrians living in Turkey, their houses damaged, and they forced to go back to their country. So some of the patients receiving treatment in Turkey, border crossing stopped, the facilities in Turkish side damaged, and the treatment of the Syrian patients in their own country affected as well. So as conclusion, forced displacement of peoples due to wars, conflicts, natural disasters, these are very huge challenges for diagnosed treatment supportive care. This happens in seconds. In wars, it takes some time. But the event yesterday in Lebanon, or a natural disaster, it happens in 1 second, everything. The problem solutions multidimensional, we cannot solve ourselves. Effective communication, partnership, NGOs, UN, relief organizations should work hand in hand. There should be a program for preparedness, allocation of more financial resources for quick recovery. Thank you.
Yeah, that was absolutely brilliant, and I hope gave you a sense of what we're talking about, resilience and continuity planning. And again, just to recognise Takia and all the colleagues there, some outstanding research, actually. This is the sort of work that's needed to underpin. We now pivot to talk about Lebanon, and it's a great pleasure to introduce a colleague and somehow distant relative, Caroline Javor, from the Mount Lebanon Hospital University Medical Center, who's going to talk about the interface of conflict and also the economic crisis in Lebanon. And again, we just want to send solidarity to Lebanon at the moment. It's an extremely difficult time. Please, Caroline, the floor is yours.
Hello, thank you for the invitation. To start, I was concerned I was not able to come here. Now I'm concerned I will not be able to leave. So what happened? To start with, Lebanon is a very small country. It's around 4.3% of the size of the UK. It has 6 million people, half of them are refugees, 2 million Syrians and over 1 million Palestinian. It's number one in refugees per population. It lived in his history a series of events, of unfortunate events, that left this small country in a crippled state, swamped with political corruption, nepotism, fragile infrastructure, and overall dysfunction. In terms of cancers, we have at least 13,000 new cases each year. It's maybe the highest incidence of cancer amongst the Arab countries. And we have, before 2019, a good infrastructure for oncology care. We have at least 10 cancer centers. Well, not all fit the definition of cancer centers. 12 radiation therapy centers. We have a good number of doctors. We have a big shortage in nurses. We have primary healthcare centers that are run majorly by NGOs. 80% of our drugs are imported, and our patients pay at least 30 to 50% of out-of-pocket during their treatment. We have also a national tobacco cancer program, cancer screening. And since 1999, the Ministry of Health has provided free medical drugs, even the most expensive one, to patients who don't have any coverage, which means 50% of the patient, going to a cost of $52 million in 2016. So our healthcare system was forged by events, by wars, by revolutions, and it is forged to grow as a resilient healthcare system. Resilient because we have the public and private sector partnership, mainly relying on the private sector. We have the aid from NGOs. We have a significant fragmentation in the funding of the healthcare system, despite the no public governance, despite the corruption, clientelism, and favoritism. And as if we wanted to test this myth of resilience, unfortunately, we have in 5 years a series of unfortunate events like the COVID, a dramatic increase in the numbers of refugees, the economical crisis, the port of Beirut explosion, and the armed conflict, all in 5 years. Why we should talk about this crisis, the economical crisis? Because it's far more prevalent than we dare to imagine. So you see, since the 1980s, at least 10 big economic crises have hit all over the world, not only in the Middle East, not only in Africa, not only in Latin America, even in Europe. So that's why we need to emphasize on the impact of economical crisis. So just to take about the numbers in Lebanon, till 2023, we have skyrocketing numbers in inflation rate, in cash and economy, in decrease in GDP, so we were classified as the top 3 economic crises in the world. 2024 update, we started our recovery, we started our convalescence due to the private sector intervention and expected 1.7 growth in GDP, 0.5% growth in economy. To resume this, so we're starting with no public governance, corruption, clientelism, extreme dependence on private sector, no regulation, with a very good incubator, political instability. And this has provoked a cascade of events, going from currency devaluation, loss of purchasing power, restriction of withdrawal, loss of savings, leading to poverty, extreme shortages, unable to transfer money, financial sanctions, and it had an important impact on public services in daily life, like closed businesses, electricity outage, disrupted transformation, manifestation, and the main important thing is the unemployment rate that reached 40%, and this led to youth migration, brain drain, and skill exodus, and was affecting 2 sectors, healthcare and education. And to close the loop that started with political instability, it also has political block, no efficient reforms, no crisis management. So we expect electricity outage, power outage, subsidies from government that faded away, no social security. But I think the healthcare in Lebanon have received a double hit that really shaped its resilience. The first hit is the healthcare worker exodus. So from 2019 till 2021, we have 30% of our nurses, 40% of our doctors who have left the country. Now the numbers are higher. We are still struggling with recruitment and retention. Also, the second hit was the extreme shortages in drugs, going from the small Panadol till the very important medication for cardiovascular diseases, for chronic diseases like diabetes and cancer. And it all have exerted pressure and strains over the hospitals. And this was exacerbated by the port explosion, just to tell you that we lost a lot of cancer drugs in warehouses in the port, and they were not recovered, sure. And all has affected the cancer care, the mental health, the screening, and limited access to healthcare, and increased reliance to NGOs. So if we want to focus on oncology care, also it has affected all the workflows, starting from screening. We have delayed screening, inaccessibility to vaccination, impacted the diagnosis. So you can imagine someone doing mastectomy without a biopsy to decrease the cost of the treatment, and increased cost of surgery, so the surgeries were delayed, and most of the times they were suboptimal because they were performed by not skilled people, not competent people who remained in the country. The effect on the medical oncology was the unavailability of essential chemotherapy drugs, treatment delays, interruption, expired or substandard drugs, and the falling below international care standards. And here I really want to emphasize the drug crisis. In 2019, the government said, well, let's use the small amount of remaining money to subsidize important treatments for cancer, like immunotherapy and targeted therapy, and it was the worst decision because of the persistent currency depreciation. It led to smuggling to other countries. So the drugs were not given to our patients, they were smuggled to outside Lebanon, stockpiling by individuals, frequent stock depletion, and drug import delays. In parallel, there was the flourishing of the black market. Mafia groups exploited desperate patients for expensive medications, and patients were forced to obtain drugs illegally. But our medical oncologist has coped with this situation. So we have on-off prescription policy. So the drug is available, you take it. Not available, you cannot take it. And this has very nasty effect on treatment outcomes, because we know that for CDK4/6 inhibitors, for example, once you interrupt the treatment, it leads to rebound in tumor burden. Switching brands, underdosage, half dosage Keytruda, for example, deviating from dosage recommendations. And this asks an ethical dilemma, because we were obliged to have decision to whom we are give the medication. We have two patients, one will live for 3 months, the other for 1 year, for example. We don't know how to decide. Inequity based on financial ability and drug availability. For radiation therapy, I'm a radiation oncologist. I've done a lot of work for radiation therapy, but we are the least to be affected by the crisis. We were immune till now. We had equipment breakdown. We had department shutdowns. 2 departments of radiation therapy were shut down because they were unable to pay the maintenance. The fuel crisis affected the patients coming to treatment, so it was a barrier, because if a patient was having a wage of $60 and they have to pay 20 liters of fuel, $20, he will not come to the treatment. And the most important, it was the difficulty to retain our RTTs, the therapist technicians, and the medical physicists. Palliative care, I won't talk, it was not existent anyway. So it has increased the morbidity and the mortality. We don't have specific numbers, but we know that with the interruption and delay of treatment, we will go to this outcome. And we have a psychological impact. So we have the emotional toll on patients and families, anxiety, depression because of the financial burden, medication shortages, moving files, because you have a doctor following his patient for maybe 5 years and he has left the country, so the patient needs to take his file, go shop around to get another doctor. And someone even goes to do foolish and crazy things just to get money to pay for the hospital. And we have the burnout in medical staff because we were overworked, underpaid, and we have concerns. I was not able to pay my membership. I was not able to get webinars to assist to continuous medical education, and this has affected me a lot, more than the income in itself. So how we coped? Remittances from a large diaspora. And here we see the Western Union opening in all the hospitals, the bags, the luggages filled with milk, with medications coming from diaspora. So every Lebanese, when coming home, he has a small bag for clothes, a big bag for medication. Telethons, fundraising, Russian private insurances, use of generic and biosimilars, more affordable sources of cancer from Turkey, Egypt, India, and Bangladesh. With bad times come good times. So there was some positive aspect of this crisis. Our patients became more demanding in terms of quality of care. We have the institution of the National Cancer Program with the great help of Professor Anhouri, who is present today with us. The creation of the WAMAN, which is a kind of medical tracking for drugs to limit abuse and limit smuggling, reduce abuse and medication usage and imaging prescription, shift to green energy in hospital like solar panels, and for radiation therapy, well, it has a very positive effect because it increased referral to radiation therapy. So we had patients like no evidence of disease for 3 years on Tecentriq. When Tecentriq was in shortage, they developed brain metastasis, bone metastasis. They were sent to radiation therapy. We did not see those patients before because they were bombarded with targeted therapy, immune therapy, because we have some secondary benefit for medical oncology. trying accelerate shift to new hypofractionated regimens, trying to create local residency program for RTTs and medical physics, using e-technology to collect toxicity data. So these global challenges, no one is immune. They affect the vulnerable population, making them more vulnerable, and create new vulnerable groups. Climate change, nuclear war, global recessions, cyber attacks, and pandemics. No country is crisis-proof. And yesterday, when I was attending Professor Sullivan's meeting, I received this message convoking us to the ER department at 4 p.m. And there was an attack, a detonation of all the pagers that were held by the Hezbollah militants. In 1 hour, every ER department in more than 8 hospitals in Beirut and in more than 20 hospitals all over Lebanon, you see the map down, have received in 1 hour more than 200, 300 injured with very severe injuries, especially in the eyes, in the face, in the genitalia, and in the abdomen and lost fingers. So which department, ER department, could manage this? And we are sure that there are some patients who will lose their life while we can save them, but we don't have the resources. Like Professor Anakak has said, it happens in seconds. So lessons to be learned towards hedging our healthcare systems. I'm here to raise awareness about the fragility of our healthcare system. No one is immune. Vulnerable patient groups, such as those with cancer, are particularly at risk and often face dire consequences with little chance for recovery. We need to establish more sustainable workflows that operate independently of political influences and universally accessible. Additionally, we should leverage technology, AI, and e-health solutions to reduce costs and create targeted, efficient strategies. Thank you a lot.
Wonderful, brilliant and sobering talk, I think we'll all agree. And to give you some idea of just the sheer complexity of these interlocking crises. And I think the lesson as well, and we'll probably hope to talk about this a bit later, is why we see the similarities around the world as well, and comparability, I think, with Turkey as well in certain elements. Our next speaker, we're going to pivot now to continental Africa, particularly sub-Saharan Africa, and I can think of no better person than Professor Nazik Hamad to talk about crisis and conflict across the African continent. Nazik's also the chair of the special interest group of Aortic on this. And for those of you who haven't seen it, this is the front cover of The Economist, Sudan, all over it. So please, Nazik, the floor's yours.
Thank you so much.
So let's do the slides outside. Hopefully.
Thanks, everyone. And now we move to a whole continent. I have no conflict of interest, but I do have family who has recently have to move all the way from Sudan to, by land to Eritrea and then to Ethiopia and all the way to Rwanda because of the war that started last year in April. And we lost many family members who are still in Sudan. So if we think about how many countries are involved with conflicts in Africa, we have around about 35 armed conflicts in 16 countries. And so many of these are in contiguous stretching region from the Western Sahel with Niger and Mali all the way to the Horn of Africa, encompassing the Great Lake Chad Basin and the Great Lake region. And if we ask how many people have been displaced by conflicts in Africa, so this including IDPs and refugees, conservatively it's 40 million, but we think it's much more, and if we add Sudan to it, it's now probably 50 to 60 million. This figure has doubled, more than doubled since 2016, and more than 77% who are displaced remain internally displaced. And contrary to what people think, actually 96% of refugees stay in Africa. So although we're familiar with this, menace to Europe, coming through people crossing and dying in the, most of them dying in the Mediterranean or the English Channel. These most of the people actually remain in the continent. And just to get a sense of geographical, the geographical clustering, we have what we call the African arc of instability, and these areas or belts stretching all the way from Mauritania to Eritrea and down to Somalia and Central African Republic, and most of this area is what's known as the African Sahel. It used to be actually called Sudan. So the entire area in olden days used to be called Sudan because all the lands below the Sahara is called the land of the black. So even Senegal was part of Sudan one day. And the Sahel crisis, and this is according to the WHO report from 2020, and it's just concentrated in the western part, is one of the fastest yet most forgotten crises in the world. Armed conflict, climate change, and I call it injustice because most of the pollution and the garbage we did not produce in Africa, but our people in the Sahel region are the ones who got the effect of that: food insecurity, disease, loss of livelihood, and political instability. And some of you may remember the war in Darfur around 2003, and Darfur is the western region of Sudan, and it's actually my family lives in the next region next to it immediately, which is called Kordofan. And this war is considered the first climate change conflict in the world in this century. So it's a convergence of environmental, political factors leading to conflict. And if we look at the environmental devastation, this is Lake Chad, which is actually a very important water basin for including Nigeria, Cameroon, Chad. All of these countries share in it. That's a satellite view from 1973, and it has shrunk by 90% in 2017, so you can see the impact of the nomadic pastoralists or the settled farmers in that area and the devastation. So this is a question really until very recently, nobody has asked this question: what are the cancer care needs of African conflict-affected populations? So if we take a look, and data has emerged as very important. We have seen a lot of data in the previous presentation, and I've created this slide last year and I've updated it today. And so just looking at one, like PubMed, which is one search engine, and just put conflict, cancer and conflict, and then put the country's name. So so far, Syria, 241 publication, Ukraine, 494 publication, DRC, Democratic Republic of Congo, is 0. Of course, these are not perfect because I know of 2 publications at least. Somalia is 0, and Sudan is far. And so we have to ask ourselves why there was 16 countries, 100 million people, and why is the spotlight not on Africa? Part of it are internal reasons, factors within Africa, because most of the time the emphasis is on immediate effects on crisis, epidemic, Ebola or cholera, and also so far there is a mismatch between cancer as a public health threat and its position in the priorities of countries and continental agenda. Most of the time people think it's not really cancer that's emerging as a major threat. Part of it is weakness of cancer leadership within the continent. Hopefully we're seeing that changing and getting better. And then weakness of the relationship between African Cancer Organization, African Union, and also no representation of cancer in the peace of agenda. There is also weakness of the research infrastructure and data collection system, skewed research priorities because a lot of the funding sometimes come from the global north, and for the global north, studies on conflicts have not been prioritized yet. Weakness of crisis preparedness and measures at the National Cancer Control Plan and MOH level. The other thing is that conflict zones are countries that tend to have no or very little cancer care available. So if you take Central African Republic or Chad or Niger or Eritrea, infrastructure is very minimal or non-existent, or South Sudan for cancer care. Conflict zones are typically countries that excluded from African and international partnerships. So when was the last time you have heard someone from Somalia come and talk, or from Chad? However, what happened in Central Sudan is that you are surrounded by all of this area, which really has a lot of conflicts. In Central Sudan, which used to be relatively safe and had a lot of cancer care, is now caving in. So it seems after years, when the periphery is in distress, the center will also collapse, and that's something to learn from. And if you see in this map, there are most of these countries, 28 countries, have no access to radiotherapy whatsoever. So there's no radiotherapy, single one in Eritrea or in Somalia or in South Sudan or in CAR or in Chad, all of these countries surrounding Sudan. External factors, I think part of it is simple, old-fashioned bias, and it's not old-fashioned, but it's current, and our pride racism against Africans, and the death and destruction, as Black Lives Matter has shown, is less important, not going to be on the limelight. Preference of international global community to working with countries that are in Africa stable or in geographically desirable locations, which are mostly in southern Africa, and geopolitical factors such as the prolonged U.S. sanctions against Sudan, which has really affected especially the radiotherapy capacity, and the marginalized status within the political space in the world of these countries. So all of this created a mix of internal and external factors that created a climate of helplessness, hopelessness, and fragmentation. Nothing can be done. That's the way it is. So Sudan really has this conflict in Sudan has helped put the focus in Africa. I'm not going to spend more time on it because we will have a talk later on. So just to know, it's really, Sudan has been a regional cancer care hub in the midst of what I call a cancer care desert zone. So all of these countries, Chad, Central African Republic, South Sudan, and then all the way extending to Mali and Niger, have very little cancer care. And we had the oldest cancer center since 1964, and decentralization of cancer care has resulted in several provincial cancer centers and partial universal health coverage for medication and for radiotherapy. And so right now, the crisis is that, according to the IOM, Sudan faces the world's largest internal displacement crisis, which will come to as news for many of you. And the fact, of course, radiotherapy, the two radiotherapy centers are no longer functioning. Cancer medicine and pain medicine supply chain is disrupted. The cancer surgery, again, childhood cancers, and the workforce, we lost a lot, and also no salaries. And of course, the effect on the region. So when people, I remember in Toronto, when the Eritrean colleagues and Eritrean friends is like, what if that happened? Our patients, where are they going to go if Sudan collapses? We have seen a lot, the picture's not as bleak in certain aspects, because patients were sent to the provincial centers, the diaspora. Some of that what we saw in Lebanon also happened. And we found that the two more important lessons is that the investment in workforce. So Sudan had trained its own local cadre since the 90s, and so far ahead in many African countries, and investment of decentralization of cancer care that will allow people, internally displaced people, to go into the periphery. And remember, most people remain internally displaced. The lesson that we learn also from the case of the Sahel is from Sudan, why is the Sahel not coming together? And this is the reality of Africa. For example, Sudan is a leading force in the IGAD, but not a member of the Eastern African bloc. For colonial and historical reason, Sudan is actually a member of EMRO, but not a member of AFRO. So we are together in the same organization as Afghanistan, but all of these 6 other countries we are not with them in the WHO. This is just at the level of the WHO. There is also the colonial legacy of fragmentation and arbitrary delineation. So Chad, we are connected historically. Same people live across the border, but the border has cut us. On this side, these people are francophone, and this side, these are anglophone. This side, people do most of their work with France, and so all of this fragmentation is affecting our ability to come together. So if we go to Central African Republic, this is a very long, but I just want to, this is just kind of a narrative of all the what's going on, and nobody knows about the conflict there. 5.6% of the population died in 2022 alone. Here is the IEA. They did a report with an impact reviews, which are excellent reviews, on 2021, and it was done virtually. Okay, and so that to tell you on CAR, and unfortunately there was no mention of why it's done visually and a mention of the impact of the conflict there. Niger, important country in the middle, they had their radiotherapy started in 2021. They had 6 medical oncologists and 2 oncology surgeons, but they get so much traffic of refugees, those who have been returned, you know, from trying to go to Europe. They bring them down from Algiers to, they get captured and bring back to Niger, and also those coming from Nigeria also trying to cross. And so in this crisscross, there's pressure, enormous pressure on only these 6 medical oncologists and their husbands. So even when a country tries to develop its capacity, it's decreased. So in summary, the response to cancer care needs in African conflict-affected care population, we haven't seen any evacuation of children. For example, in Sudan, they are actually in a relatively safe area in Merowe. Nobody has offered to evacuate them. We are seeing, relapse of ALL and death in children that shouldn't be happening. There has been no major funding to support cancer medicine and other aspects of care for any of these countries, and no concerted efforts to provide cancer care in neighboring countries that have some capacity. So what we are actually seeing is what I call the invisibility of cancer in the Sahel and sub-Saharan Africa is this kind of vicious loop of conflict and climate injustice leading to decreasing access of cancer care. And that access in cancer care also fueled the conflict, because we know there is a really direct relationship between having a radiotherapy machine and being in conflict. And so this cancer and war matter because cancer does not know whether you are in a conflict zone or not. 86% of NCDs happen in LMICs, and 96% of refugees and internally displaced remain in Africa, and the average length of displacement is for the refugees 20 years and 10 years for the IDP. So what can be done? We need African solidarity and conflict preparedness. We can change that. We need to equity in investment in cancer care in conflict-prone area. Addressing climate injustice is part of it. And access to health care as a cause, not just an effect of conflicts, because we've seen that those who don't have access to health care are more likely to be conflict-prone. And the new reality that we have to deal with is that conflicts are happening in cancer care hubs. That's what we see in Sudan, and there's a need for global action. We need to have a continental action. We have created a body within AWOTIC to coordinate research and response, and there has to be some solidarity and equity between countries, and we should ask who's here, who's not here today. And finally, I think we need a global paradigm shift as looking at cancer as a major health threat. If we're talking about it all the time like that, so we must make sure it actually has its place in the agenda for peace. So thank you.
Nazi, brilliant, sobering, brutal as ever. And we turn now really to our last speaker, and last but by no means least. The war, Russian invasion or extended invasion in February 2022 has been raging in Ukraine. there's been, as you've seen from Nazik, a lot of academic work in this looking at resilience, and it's a great pleasure to welcome to the stage Inessa Winuk from the National Cancer Institute of Ukraine to talk a little bit about the medical evacuation work and the further impact of the conflict in Ukraine on cancer patients. Inessa, please. Thank you.
Thank you. It's a big honor for me to be here today and share the Ukrainian experience. And I have nothing to disclose. As you all know, that the full-scale Russian invasion into Ukraine started on February 24, 2022. And since that time, 1,521 attacks were launched on Ukrainian healthcare system, 773 attacks damaged or destroyed hospitals and clinics, and 234 healthcare workers have been killed. But one of the most vulnerable populations during war is cancer patients, and they needed their continuous and multimodal help even though the war has started. In order to address the issue, the medical evacuation cancer program was launched in April 2022 between Ukraine and European Union, which was just a little bit more than 1 month after the full Russian invasion started. The whole program started with an open letter from the Ministry of Health of Ukraine to the Healthcare Division of the European Union. In order to ensure the international network and support, WHO and Emergency Response Coordination Center got involved. This program focused exclusively on adult cancer patients, and for children with hematologic malignancies and solid tumors, another program was launched. The panel of experts from Ministry of Health of Ukraine and ERCC was needed to ensure the quality of the program. And here's the algorithm of the patient evacuation, and this is how it's today been done. Everything starts with application submission. Patients can apply through NGO for patients, they can apply themselves of the Ministry of Health website, and also they can apply through their medical oncologist. Application is reviewed by experts, then patients are selected due to criteria. Evacuation is prepared. Then patients arrive at the medical evacuation hub, which is responsible for pre-flight medical stability of patients. Then they depart from the medical evacuation hub, get to the European country to get their treatment, and then they return to Ukraine. Here are the results of the first year of the program. And we know and we understand that majority of people and patients who applied for cancer care abroad were patients with melanoma, breast cancer, and chronic hematologic malignancies. And these are the patients who eventually got their help abroad. EHOG 0, 1, and 2 were associated with the ability and chances for patients to get transferred abroad. And systemic therapy was the main reason why patients with cancer were applying for the medical evacuation cancer program. Here are the limitations. We don't have, unfortunately, the information about medical refugees. We know only about patients who went abroad to get their treatment through the medical evacuation program, but zero information about medical refugees. Also, there is a lot of lost data. Follow-up recording after patients come back to Ukraine need to be improved and need some more interactions to ensure the stability and more information. And continuation of treatment for this patient is a huge issue in Ukraine, as Ukrainian government cannot provide specialized care and specialized treatment. And here are the other challenges for cancer care in Ukraine during war. Quality of medical education. It needs to be renewed. It needs the intervention from abroad to get more structure. Diagnostic and treatment delays are still present because of internal migration and overload in the western and central part of Ukraine. Shortage of chemotherapeutic agents is one of the main issues, as only 65% of chemotherapeutic drugs is provided by government due to lack in the budget. There is a total and absolute absence of targeted and immunotherapeutic agents, and lack of medical supplies. All of this leads to out-of-pocket payments, which is obviously negatively influence the social and economic status of Ukrainian population. The standards of care need to be renewed, need intervention from international society to get more complex and include psychological support, fertility issues, and quality of life issues. Quality and safety programs need to be implemented around the country and deal with low compliance and monitoring. Collecting data is another challenge, as we don't have information about occupied territories, how cancer care is provided there, and even if it's provided there. Cancer registry needs to be renewed, it needs to be more structured, and clinical databases needs to be introduced into day-to-day practice in hospitals. Healthcare literacy is last but not least challenge for cancer care in Ukraine, as we know, and we have suboptimal doctor-patient relationship and incomplete understanding of the treatment plan by the patients. In conclusion, medical evacuation cancer program can serve as a blueprint for future initiatives in other humanitarian settings. But if it was not for the shortage of chemotherapeutic agents and lack and absence of immunotherapy and targeted therapy, these patients would stay in Ukraine and be productive members of Ukrainian society. Ukraine still needs continued support from global communities, and patient organizations in Ukraine are change makers that lead a lot of national initiatives and require global support. Patients with cancer in Ukraine fight two wars at the same time. Just to remind, thank you.
That's a wonderful talk. Thank you very much. And I also want to recognise the wonderful collaboration you had with MD Anderson and the support. And I know there's a number of members here, nearly a dozen people here. So thank you as well. I'm going to take Chairman's prerogative. I know we're nearly at time, but I think they're four of the best talks I've heard on the subject. And I'd like to invite all the speakers up to the stage and let's have some questions and a bit of a discussion. And there are obviously some areas we haven't touched upon, issues of disinformation, the cyber attacks now that are increasing against medical facilities. Let me go over here and grab this. Hopefully these should work. And we'll keep going until we get kicked out. Please.
Srinav Ratnam from Canada. As you said, it's a really excellent session and a sobering one, and brilliant work all of you are doing, so thank you. My question is not the immediate one, the long-term impact. The people living in the conflict area, especially the war, armed conflict. Is there any work being done, how they are, the cancer incidents? Do we need to screen them differently? Is there, I'm not familiar with those work, so please, thank you.
Yeah, it's difficult, of course, because people are displaced, not living in their, let's say, original houses, internally displaced or externally. So in some places, it's not even accessible for doing screening or to find the population living there, and medical officers cannot access. And this is the worst. If patient has a cancer, sooner or later it can access the treatment. But I don't think in their conflict zones anybody taking about cancer screening or finding the cancer incidence or doing some statistics. It is very, very difficult to do estimates.
Yeah, there's some nice piece of work by Paul Spiegel from UNHCR. I can tell you where the reference is, but generally speaking, the epidemiology of refugees and conflict is really poor when you look at the reviews. Please, Mark.
Mark Lawler, Queen's University, Belfast.
Yeah, sorry, Mark,
sorry.
hang on a second.
Yeah.
I'll let Caroline.
I just have a comment also for zones of armed conflict and refugees, that also the patients, they don't have the mindset of screening because this is the least of their problems. So even if they have access, although limited, they will not go because they prefer not to know they have cancer and focus on other things.
Brilliant point. Please, Mark.
Mark Lawler, Queen's University, Belfast, but more importantly, co-chair of the European Cancer Organisation's Special Focus Topic Network on Emergencies and Crises. Really thank you to all four of you really for illustrating the big challenges that we face in relation to cancer and conflict and cancer and natural disasters. One of the things that's really important, I think, is you've all learned different things in the context, and it's how to bring that together. Because I think we can learn from each other in that context. And just in that context, one of the things we're trying to do is to do exactly that in the Special Focus Topic Network. So we really welcome people reaching out. We're going to have a session at the European Cancer Organisation Summit in November in Brussels. But we want to try and bring together that different experience. We met with some of the Ukrainian delegates yesterday, and also bring together the likes of ECO, ASCO, UICC in relation to this, because we have shared challenges here, and the only way really to do it is to work together to share those challenges, but also the lessons that we've learned. So thank you very much indeed to the four speakers.
Thank you so much, Mark, for that intervention. That's brilliant. Tessa, please.
Tezer Kutlu from Turkey. I just want to make a short contribution what Yavuz said. Turkey is spending a lot of money on the cancer in Syrian refugees, not only the cancer, but also other fields. But investing money only does not help the survival of the patients. What my group did, we did two major work on the life of the Syrian cancer patients in Turkey, and the survival rates among the Syrian cancer patients living in Turkey goes as low as 17%, which is not acceptable. So we are investing only the post-migration phase of the process. Nothing to do with the pre-migration phase and the migration phase of the process. So the best is the prevention of the conflict. It's just investing money just helps partially solves the problem, not a total solution. Thank you.
Thank you very much indeed, Tez. And by the way, Tez has got a fantastic paper on survival of Syrian refugees. I think, and again, pointing to treatment, abandonment, late-stage diagnosis, all things he talked about. Please.
Thanks. Moira Lang, I'm a palliative care physician working in global health and in fragile settings, in particular in northern Uganda and Gaza. Brilliant, brilliant talks. Thank you so much. A couple of you mentioned just the word palliative care, but could you just comment, because I think particularly when access to treatment is compromised, the role of palliative care is even more important. So could you maybe just comment about integrating palliative care?
Maybe Nazi, maybe the whole group.
Thank you for the question. Palliative care is being provided for Ukrainian patients, but as all the other aspects of cancer care, it's located at special centers, at those which are more or less safer than others in the central Ukraine and in the west of Ukraine. Not all the regions can provide that, but no matter where this patient lives across the country, he can get or she can get her palliative care across the country.
Can I comment?
I think for us, we had a huge problem with the supply chain of palliative care medications, number one. And number two, unlike in Lebanon, the patients actually need more radiation because of the disruption of the medical blood bed. With the machines being destroyed, a lot of patients are left without. And so that's something we need to think about, and regionalization of radiation therapy in Africa, so that there's more access, because it becomes really more important. As a medical oncologist, that's what I'm saying too. So,
for Lebanon, well, the crisis had this perfect positive effect. It is on the initiation and implementation of palliative care strategies. It was noted in the National Cancer Plan. It was the top priority of the National Cancer Plan. This year we had the institution of the first Society for Palliative Care. We have a lot of NGOs working on palliative care, and indeed, as you said and you emphasized, that it is maybe the best thing to do for patients. If not give them their treatment, at least give them the best supportive care. And here I need to thank the head of one of the best NGOs that worked during these 5 years, Hani Nassar, Barbara Nassar Association. They worked a lot in palliative care, providing medication, not chemotherapy, not targeted therapy, but morphine, and because there was shortage in pain medication in Lebanon.
Regarding the 70 patients of all cases are diagnosed in late stages, and more than 25% of discontinuation treatment. For most patients, the palliation is the only option. So, but this is not structured in many places in my country as well. So I think we should think more of that with the contribution of the NGOs and other organizations. It's extremely important, and in many cases it's the only option.
Thank you.
So, hi, I'm Jean-Marc from Canada. Nazik, the slide that you presented with the list of publications, depending on where you're from, is very striking. Obviously your priorities change if you're in a war. I think you don't submit to publication, you don't submit to the author submission page, probably have other priorities. But I would ask you all if you could comment on that lack of representation when it comes to sort of publication, or even it's represented in medical conferences. Certain groups have a a very good representation and some others don't? And do you think it's an incentive to sort of change the way that we engage internationally with certain actors in order to sort of change the politics of how health is being done? It's a loaded question, but.
I think the first thing is to make people aware of the problems, because really cancer and conflict is never been on the agenda when it comes to Africa. It's just like there's always going to be conflict there, but nobody thinks of actually there are patients there are people who are going to be affected with cancer. Now, I think what happened with the conflict in Sudan, especially that a huge infrastructure of cancer care has been almost demolished. I think we are seeing more, we're now having a place in the platform, but for me it's also important not to see it as a problem of Sudan, but to see it as a problem of these vast, vast areas of people extending all through the Sahel and down into a lot of areas of sub-Saharan Africa, affecting millions of people. So that's actually number one. Number two is also for people who are doing partner in, our global North, global South partnership. It should come as an important area that need to be investigated, and so no grants will ever have been looked at that. And then number three is, of course, to make sure we support bodies like the aortic SIG, where any attempts to generate data, to make research happen in that area, and also look into the area of climate change and its effect on cancer. So all of these should be emerging disciplines, and they should be emphasized. They need funding, they need platform, and also to partner with people in Africa, especially the emerging cadre of oncologists and researchers, to make sure that actually will happen, so that we can change that actually very bleak slide as to the amount of data. Like, I cannot present an amount of data because it's not actually there. It's very difficult to collect data, but we have to start somewhere, and we have to put this on the agenda.
Just Turkey, you've done a lot of research in this. Do you think it's influenced policy and practice?
Not really. But there's, it was a very, very good slide you showed that this can happen to anywhere, anytime, crisis. Right now, people crossing the Mediterranean, immigrants, but 70 years ago during Second War, it was on the other side. So from the Aegean, from Turkey there's an influx of refugees to Greece. But in 60 years ago, 50 years ago, the Greek junta, it was on the other way. So today, it seems to one way to Europe, but who knows? It can happen anytime and on the other side. So this is a problem for everybody, for rich countries, poor countries, everybody.
Hi, everybody. My name is Daria Kizub. I'm an assistant professor at MD Anderson Cancer Center. Thank you so much for your very wonderful presentations. My question is about where you would like to maybe see some of this move forward in terms of international collaborations, and in terms of coming up with kind of a more standardized, formalized response to how to optimize cancer care in emergencies, whether that's armed conflict or natural disasters, because there are same challenges related to medication procurement, personnel shortages, equipment, surgical equipment, radiation, oncology equipment, providing palliative care, medical evacuation, and collaboration between nearby countries and international bodies. I know Mark Lawler already said that there's going to be additional discussions, but I just wanted to ask each of you kind of what do you think would be most helpful in the future to help your countries or the region in this area, just because it seems like these challenges are going to continue and only grow, unfortunately. Thank you.
Yeah, I think for us, the most important thing is to realize that there are cancer care desert zones within Africa, and these should no longer exist. If there was cancer care in Eritrea or in Chad, because from the experience from Turkey and from Ukraine is choose thy neighbor. Can your neighbor help you? Can your neighbor absorb some of the refugees? And what is your pre-existing radiotherapy and also, medical oncology capacity? So we need to make sure that when the areas that have relative peace also cancer is upscale, so it has to be regional. People have always said, oh, this country doesn't, like the data is always kind of isolated from each other, but we need to come with a really strong regional plan for all of these conflict-prone areas and make sure that they will be able to provide solidarity in each other, so upscale everywhere.
I think, first of all, like concerning your question, the policymakers should find another way and have their own view how to improve the situation. Because a lot of advice and a lot of support is coming to Ukraine at this time, but it's very important to have one direction, and all of them should go into one direction. Another thing is that the healthcare system in Ukraine needs to get more structured in terms of electronic systems and databases, so we can at least follow our data and compare what's happening. The same is about like medical supplies and drugs. If we have databases which are transparent, we know where patients can get their treatment and how those supplies can be transferred across the country.
For me, it's one word. You need to empower the persons on the ground, because it's all about political decision. It's not, I can do nothing with a national cancer plan that is well written if I cannot implement it, and if I don't have the authority to implement it. So people who are working, they don't have the authority. And the people who have the authority, they don't have political interest in improving things. That's why we need to work more on protecting healthcare, protecting oncology care from the interference of politics. This is my message.
The first thing is there are no guidelines. So they were very basic, very simple, and there should be guidelines for how to manage this crisis. Not all crises are the same. Some crises are extending to years, and like the war, internal conflict. So it's settled a bit, but some happens in seconds. So these should be guideline plans for this. IAEA is now taking action for radiotherapy part, but I need there should be the collaboration with others.
Ladies and gentlemen, it's been a fantastic session. We've gone wildly over time. Please give them a very round of applause. Thank you very much. And thank you everyone. Brilliant, absolutely brilliant.